Welcome back to the Rebel Core Content Podcast. Core content for anyone, anywhere, and just in time. This is Swami, and this week I want to get into angioedema. Angioedema is defined as a transient, localized, non-pitting distension of the skin. That's what we typically see, but the respiratory and gastrointestinal tracts can be involved as well. Inflammatory mediators cause increased vascular permeability, which allows fluid to diffuse into the interstitium, which then causes the swelling that we see. It typically affects areas with loose connective tissue, so the oropharynx, the extremities, and the genitalia can all be involved. This is not a super common presentation, but one that we do see frequently enough that we need to know how to deal with it. And the most common agents that can cause it, as far as medications, are non-steroidal anti-inflammatories and ACE inhibitors. I think ACE inhibitor angioedema is the classic one we see in the emergency department, but we have to remember that NSAIDs can also have this effect. There are two major pathophysiologic mechanisms that we are focused on in the emergency department, and it's important to know these because they do dictate your management. There are those patients with mast cell mediated angioedema. These can be both IgE dependent as well as IgE independent, and NSAIDs fall into this category. The other major group is the bradykinin-mediated angioedema. This is where ACE inhibitor angioedema lives, also hereditary angioedema and acquired C1 inhibitor deficiency. The mast cell-mediated variety is very similar to what we see in anaphylaxis. There is mast cell activation, which leads to the generation of mediators like histamine and leukotrienes and prostaglandins, which increases vascular permeability. Many of these patients will present with a rapid onset of symptoms, and they can feature urticaria and pruritus, again, similar to what we see in anaphylaxis. When we look at the other major variety, that bradykinin-mediated, this occurs when plasma globulins like kininogens release bradykinin and cause vascular permeability. This is very different than the process that we see in anaphylaxis. There is typically an absence of urticaria or pruritus, and this can be more of an insidious onset, coming on over 1 to 2 days. Again, this is where ACE inhibitor angioedema lives. It's the bradykinin-mediated variety, and we will typically see involvement of the mouth, the larynx, the pharynx, and the subglottic tissues. Whether the patient is in the bradykinin-mediated or the mast cell degranulation type of angioedema, there are some features that are going to be different than anaphylaxis. Yes, that mast cell type can have things like urticaria and pruritus, but they'll also tend to have asymmetrical swelling, which is the classic of what we see with ACE inhibitor angioedema in that bradykinin group. In terms of management, the thing that we are most focused on is, does this patient need airway management or not? This can be very tricky, especially in the bradykinin-mediated group, in the group with ACE inhibitor angioedema, because often they will have swelling of the lips, of the tongue, but they have a stable airway. The swelling that they come in with may have been going on for a day or two, and they've been maintaining their airway just fine, but when you look at the swelling, you kind of want to do something, and this is really part of the trick. We have to be cautious in deciding to take the airway or not, but at the same time, if we see rapidly progressive swelling, or if we look at the patient and say, there is so much anterior swelling, I'm worried about this patient losing their airway, we may have to make a plan for an airway intervention. There are often some cutoffs that people talk about if the patient has edema of the anterior tongue or the base of the tongue, if the larynx is significantly involved, so if the patient has things like throat tightness or stridor, those are patients where the airway should be managed. But again, this can be very tricky because the typical approach to airway management that we take with rapid sequence intubation through the oropharynx may not be a viable approach in the patient with angioedema. So what is probably the best thing to do in these patients is to look at them and say, do I think this patient needs an immediate airway? If they do, then you're going to have to progress down that route. Make sure that you have a double setup, that you're ready to do a crike on this patient. If the patient doesn't present an immediate airway threat, but you're worried about the amount of swelling, this is the place to consider awake intubation, fiber optic intubation. If you don't have those skills, then this is a place to call in your consultants, call in your help that can take care of these airways either in the operating room with a surgical backup, or they can bring fiber optics to the bedside of the patient. But we really have to be measured in how we approach these airways. I think every clinician that has been doing this long enough has seen the patient with angioedema where there's a lot of swelling, but the patient's maintaining their oxygen saturations, their respiratory rate doesn't look too bad, and then somebody decides to step in and take that airway only to find that they cannot intubate through the mouth, and now the patient ends up in a can't intubate, can't ventilate scenario where a surgical airway needs to be performed, so we have to be very careful. If we're going to do this, make sure you have all your backups in place. Strongly consider awake intubation. Going through the nose and doing fiber optics is probably the safest approach in a awake, spontaneously breathing patient. And again, if you have that set of skills, this is the place to really use them. And I think regardless of which approach you're going to take, you're going to want that double setup. Be ready to correct this patient. Of course, what we would love is to see the patient with angioedema who doesn't have a crashing airway and then administer treatment that reverses the process. This can be trickier than it seems, though. If you see the patient with angioedema and they have urticaria, they have pruritus, that is generally going to be in the mast cell mediated angioedema group, and those patients may be responsive to the typical medications that we use in anaphylaxis. In that subset of patients, I would administer epinephrine 300 to 500 micrograms IM. You can hit them with all the other allergy-related stuff, the antihistamines and the steroids, but the epi is going to be the key in management. So if the patient has angioedema plus urticaria, consider epinephrine. In the group that's bradykinin-mediated, epinephrine, antihistamine, steroids, none of these are really going to do very much. Often these medications will be administered out of the precaution of saying, well, maybe it is going to be mast cell mediated, or maybe this is actually anaphylaxis and I am miscategorizing it, so I'm going to give that dose of epinephrine, I'm going to give those other medications. But if this is truly a bradykinin-mediated angioedema, like with ACE inhibitor angioedema, epinephrine, steroids, antihistamines, these are not going to save the day. And unfortunately, we don't really have a particular approach that is going to reverse the airway changes that we see. In patients with hereditary angioedema and C1 esterase deficiency, there is a drug that we can use. We can replace that C1 inhibitor with Baranet or ecallantide. We can actually also replace the ACE with 2 units of fresh frozen plasma as a second-line intervention. So we do have some things for the patient with hereditary angioedema and C1 esterase deficiency. These patients typically know that they have hereditary angioedema. They'll present telling you they have hereditary angioedema, and they've had multiple presentations of the same, and that leads us to give those interventions. In the patient with ACE inhibitor-related angioedema, these medications don't work. There has been some research looking at a drug called icatibant for ACE inhibitor angioedema. Studies have had mixed results, but overall, it does not seem that icatibant plays much of a role in the management of patients with ACE inhibitor angioedema, much to the chagrin of all of us who were looking for some kind of a solution. Some people have posited using fresh frozen plasma in the patient with ACE inhibitor angioedema, but we don't really have good studies telling us that this is a good move. FFP may make some sense in terms of replacing some of the enzymes that are going to break down bradykinin, leading to a resolution of symptoms. But we also have to remember that FFP has bradykinin in it as well, and so it can actually lead to worsening of the angioedema. And so while we do have some case reports supporting FFP, we don't have real studies, and so I wouldn't be reaching for this. Without a real therapeutic approach in ACE inhibitor angioedema, it still begs the question of what do we do for those patients? So again, we go back to airway. If the patient has immediate need to take that airway, then we're going to do that. And again, we're going to do it in the safest way that we possibly can, going back to the things we talked about earlier, doing fiber optic intubation, going through the nose, making sure you have a double setup. Most patients with ACE inhibitor angioedema don't need an immediate airway. In fact, the vast majority of patients will never need an airway intervention. And so for those patients, the best thing to do is to wait and to watch and to discontinue the medication that has caused the problem in the first place. Many of these patients will come in with just lip swelling or maybe just a little bit of anterior tongue swelling, and we watch them for a couple of hours. And maybe we even send them home and tell them this is going to go away over a couple of days. Stop taking the ACE inhibitor. For those patients with more significant swelling, more posterior swelling, we're still going to be watching them, but we are probably going to admit them to a higher level of care in the hospital and watch them for overnight, 12, 16, 18 hours, make sure they're not progressing, that they are improving, and then we're going to send them home and tell them to discontinue the ACE inhibitor. Before we wrap up for this week, let's hit a couple of take-home points. In angioedema, airway management is paramount. We should expect a challenging intubation in those patients who we identify as needing an immediate airway. We should always have a double setup. Fiber optics are going to be critical here, as well as an awake intubation approach. Those are tools that you're going to want to have at your disposal for this subset of patients. Understanding the cause of angioedema, whether this is mast cell mediated or bradykinin mediated, is important because it dictates our management. And remember that if the patient has angioedema and urticaria, this is probably mast cell mediated, and the standard anaphylaxis medications are probably going to work here. Whereas if they have angioedema without the urticaria or pruritus, they are unlikely to respond to those interventions. That's all for the Rebel Core Content podcast this week. We'll be back in 2 weeks with another cast. In the meantime, don't forget to run on over to the site, check out all the great posts from our faculty, and until next time, stay safe.